The broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody, and apologies for any background noise that you're hearing. That is my dog sleeping. Welcome to Reproaction's February Act and Learn webinar, Understanding the Difference, Emergency Contraceptives and Medication Abortion Are Not the Same. So I am one of your co-hosts for today. My name is Jessica Ensley. I use she, her pronouns. I'm the Senior Vice President of Outreach here at Reproaction, and I am based in Washington, D.C., and I will pass it over to my co-host.
Hi, everyone. I'm Jasmine Gianzan. I also use she, her pronouns. I am the Media Research Manager here at Reproaction, and I'm based in Richmond. Back to you, Jessica.
Great. So here is our agenda for today's webinar. I will introduce our organization, Reproaction. Me and Jasmine will dive into the topic at hand before we get into our panel discussion today, which I'm very excited for. And then we'll head on to next steps and questions. So if you have questions throughout this webinar, please feel free to enter them in and we'll get to them at the final portion. And you can join our conversation by following us on Blue Sky, by following Reproaction at our handle, or just following the hashtag Reproaction. So to start off, Reproaction leads bold action to increase access to abortion and advance reproductive justice. We are known for our left flank analysis, our willingness to hold folks on all sides accountable, whether they be allies or opposition, and we are committed to nonviolent direct action. So I will start with emergency contraception. Often known as Plan B or the morning after pill, it reduces the risk of pregnancy if taken within 5 days of unprotected sex. The sooner the medication is taken, the more effective it is, with some pills preventing pregnancy up to 95% efficacy if taken within 24 hours. Containing either the hormone progesterone or ulipristal acetate, they can be purchased over the counter or through a prescription. Emergency contraception is safe. It is not used to induce an abortion if somebody is already pregnant. Some of the types of emergency contraception include Plan B one-step, next choice dose, Ella, and copper IUDs can also be used as emergency contraception. Now, medication abortion, also known as abortion pills, that can be taken using one of two methods. The first method is with mifepristone and misoprostol, and another method is misoprostol only. So mifepristone blocks the hormone progesterone. Then misoprostol is taken after, and it causes contractions and expels the pregnancy tissue. Medication abortion is also highly effective. Within the first 12 weeks, the mifepristone and misoprostol method is safe and approximately 95% effective. For the misoprostol only method, within the first 12 weeks, it is safe and approximately 85% effective. So it is very important, and the point of the thesis of this webinar today, that medication abortion is not the same as using emergency contraceptions. Both, again, they are fine, which we will dive into on today's webinar. But emergency contraceptives will prevent a pregnancy from occurring, and they won't end a pregnancy. If a person who needs an abortion takes emergency contraception in hopes of ending a pregnancy, they will not achieve the desired result and they will remain pregnant when they don't want to be. So I will pass it over to my co-host now to talk about misinformation.
Thanks, Jessica. So the anti-abortion movement has been very adamant about trying to cause confusion about medication abortion and emergency contraception and trying to conflate the two. Obviously, here we have two examples. So Kristen Hawkins is the president of Students for Life of America, which is one of the larger anti-abortion advocacy groups in the US. And in 2023, she tweeted, "Plan B can cause an abortion. It can prevent a fertilized egg," which she called a unique human life, from attaching to the wall of the uterus. This is not true. Secondly, Marjorie Dannenfelser, who is the president of Susan B. Anthony Pro-Life America, which is another major anti-abortion advocacy group, wrote in 2013, "Teen girls need parents, not unfettered access to abortion-inducing drugs," as a reaction to a federal judge requiring that Plan B, one step, be made available over the counter without age restrictions. And that was in 2013. And obviously both of these claims are false. If you want to head to the next slide, Jessica. So to clarify any confusion about medication abortion and its difference from emergency contraception, the FDA actually updated its guidance on Plan B in 2022. And here you can see its updated guidance. Plan B, one step, will not work if a person is already pregnant, meaning it will not affect an existing pregnancy. And evidence does not support that the drug affects implantation or maintenance of a pregnancy after implantation. Therefore, it does not terminate a pregnancy. And here we can see that they really clarified the difference between emergency contraception being a contraceptive and medication abortion, which does terminate a pregnancy. And a lot of this confusion really just goes back to the overall anti-abortion agenda of pushing fetal personhood. I'm sure you all have heard of fetal personhood. It came to national attention last year with the Alabama Supreme Court ruling surrounding IVF. But essentially, fetal personhood is this legal concept that's pushed by anti-abortion activists that would give rights to embryos at the moment of conception and would treat them as real legal human beings. And this kind of legal concept would jeopardize access in vitro fertilization because it does freeze embryos. More so on this, the false information that's spread about emergency contraception and the false notion that it can terminate an existing pregnancy allows anti-abortion activists to use the concept of fetal personhood as a means to attack emergency contraception.
Thank you very much, Jasmine, for going into that. So I would like to introduce now our first panelist, Kelly Cleland, uses she, her pronouns. She is the Executive Director of American Society for Emergency Contraception. Kelly has an extensive background in research and spent 14 years at Princeton University focusing on projects related to contraception and medication abortion. As Executive Director of ASEC, Kelly creates guidelines and fact sheets on challenging clinical questions, provides expert review of EC-related materials, develops the agenda for the ASEC annual meeting, the EC Jamboree, and supports collaboration among ASEC's 1,200 constituents. Prior to her work with ASEC, Kelly evaluated comprehensive sexuality education programs at the University of California, San Francisco, and Planned Parenthood of New York City. Kelly received her MPA and MPH from Columbia University in 2002, where she concentrated in population and family health. Kelly is a fellow of the Society of Family Planning, a liaison to the Planned Parenthood National Medical Committee, and a member of the editorial board for the journal Contraception. Kelly, thank you so much for joining us here today.
Thank you, Jessica. I'm really excited to be here.
Wonderful. My first question for you, can you give us an overview on the work that American Society for Emergency Contraception does, and what drove you to become a part of it?
Sure, yeah. You know, as you mentioned in the intro, I have a significant amount of experience with research, and my research has really been equally divided between emergency contraception and medication abortion. And I'm just fascinated by, you know, the confusion between the two, the, you know, perceived overlap. So I'm really, really excited to be having this conversation today. I think emergency contraception is critically important, you know, more than ever now, given the restrictions on reproductive rights that we're seeing across the US and in other parts of the world. Some of the work that we do is really kind of in three different buckets. One is about helping to clarify some of the confusing information and research that's out there about EC. So helping people understand things like, is EC less effective for people with higher body weight? Can you use EC when you're starting a new contraceptive method? We also do a lot of work monitoring access. So we have a survey that hopefully we'll have a new report out within the next few weeks, where we have people go into pharmacies and directly observe, is EC available? How much does it cost? Is there any gatekeeping happening? Is it behind the counter? Just so we can really keep tabs on what the real world access picture is like. And this year we've got about 600 responses, so this is our biggest ever. We're really excited. And then, a lot of our work is really about expanding access in different types of communities. So our biggest kind of flagship project in this area is called Emergency Contraception for Every Campus. I'm so excited to be sharing this space today with Nimisha, who's one of our fellows in the EC for EC program. And she's done really phenomenal work, both as an undergrad and as a grad student. So cannot wait for you to hear from her. But our mission here is really to work with students, staff, and faculty, but really we focus most on students, figure out what does EC access look like on their campus, what do they want it to look like, and how can we help them get there? And we're doing increasing work, in communities outside of college campuses. In fact, we are in final stages of hiring an organizer who will be working in the Deep South with communities, with campus groups to help improve EC access.
Awesome. Thank you for sharing that. And I can't wait for your new report to be out. And when you have that, please send it and I'll share it with everybody. So that's wonderful. And again, I'm also happy that Nimisha is on to talk to us more about that campus focus. My next question for you. So, you talked about one of the sections of your work being, clarifying mis and disinformation. Has the education around emergency contraceptives changed in our post-obs reality? Or are you finding it still about the same as where we were when Roe was still in place?
No, I do think there are a lot of differences. I think just number one is that it's more urgent than it's ever been, because we, in some places, our partners who are in Texas and Florida, in places where abortion is completely banned or just very, very difficult to get, preventing pregnancy is more important than it's ever been, especially for folks who are already disproportionately impacted by bans, which are, marginalized communities. We've found more and more that it's important to educate folks about the difference between EC and medication abortion, and not in a way that we want to stigmatize abortion at all, because, it's a huge part of my work. If we were on camera, you'd see that my background is like a wall full of signs about abortion. But we want to make sure that people use the right thing for the situation that they're in. So if you're pregnant and you don't want to be pregnant and you take Plan B, you're just going to be a little nauseous, but you're still going to be pregnant. So we want to make sure that people understand the difference. We're also seeing more and more, intentional conflation between EC and medication abortion by folks who, like the people that you quoted in the beginning, that Jasmine talked about, from Students for Life, from Susan B. Anthony List. They intentionally want people to think that it's the same, and they want people to think that abortion laws apply directly to emergency contraception as well.
Yeah, absolutely. And I think that's one of the reasons, why we're having this webinar today, is that both are incredibly important reproductive healthcare choices, as you said, but understanding the difference for people who need healthcare at certain points in time is very important. So my next question for you leads into that, and in addition to some of the resources that your organization provides, is there anything you can point out specifically on how folks can correct mis and disinformation surrounding forms of reproductive health care?
Yeah, I think it's really two things. It's number one is make sure you understand it. Make sure you inform yourself. Find credible sources to really read and make sure you understand, how does emergency contraception work? How is that different from how medication abortion works? How is emergency contraception available? Where can you get it? How can you get the kinds. And our organization has lots of great trainings on this. So, we're always excited to do a deep dive on EC 101, on EC advocacy and activism, but really understand the difference and understand what EC is. And then talk about it a lot. I find that a lot of folks, even healthcare providers, even some of our most engaged student leaders, don't necessarily have all of the details right. This is a pretty complicated space. There is a lot of confusion that I think is natural, because it's kind of counterintuitive that you can use a contraceptive after unprotected sex. So I think just that piece alone really lends itself to a lot of confusion. So yeah, educate yourself, and then educate folks around you. We, in my community, both professionally and in my town where I live, I'm known as where you go to get free emergency contraception. Before my friends' kids go back to college, I always put a little post on social media inviting people to come over and grab some free EC to send to college with their kiddos. And it really opens up a lot of good conversations. So just get out there, talk about it, be really proud in your support of abortion rights like we are, and just help people know the facts.
Thank you so much. I love that, and that's someone I strive to be in my community. So I'm glad your community has that. Wonderful. Well, looking forward to hearing more from you during the Q&A section. Thank you again so much for joining us. If folks have questions for Kelly or any of the panelists as we go throughout, please feel free to enter them in, and we'll get to them at the end. Wonderful. So I will go ahead and then introduce our next panelist. Nimisha Srikanth uses she, her pronouns. She is the Regional Organizing Fellow for Emergency Contraception for Every Campus, as Kelly was just discussing. So Nimisha is a Master of Public Health candidate in Social and Behavioral Sciences and United States Health and Justice at the Yale University School of Public Health. She serves as Regional Organizing Fellow at Emergency Contraception for Every Campus and Student Organizer at Advocates for Youth, and works as a Graduate Research Assistant in the Substances and Sexual Health Lab at the Yale University School of Public Health. She is passionate about reproductive justice, health disparities, youth advocacy, and community activation. Nimisha has worked on multiple projects regarding abortion advocacy, access to emergency contraception, and sex and consent education at Texas A&M and in her home state of Texas. At Yale, she is working on emergency contraception and doula campaigns and is co-chair for the Reproductive Health Equity Now at the Yale School of Public Health. Nimisha also works as a health policy fellow at the Connecticut General Assembly in the Reproductive Rights Caucus with Representative Jillian Gilchrist, championing reproductive rights in Connecticut, and is currently working on expanding access to reproductive health products and services on college and university campuses in Connecticut with pro-reproductive rights representatives. Nimisha, thank you so much for joining us today.
Thank you so much for having me. I'm really excited to be here.
Wonderful. My first question for you is, you have a wonderful resume here. My question for you is, when did you decide that you really wanted to focus in on sexual and reproductive health, and what was that journey like?
Yeah, so I think for me, I think this is also the same for a lot of my peers, is I first started becoming interested in sexual and reproductive health through my own personal and familial experiences. As I was going through puberty and just growing up and developing into a young woman, I was just asking my mom and different family members about their stories and just kind of what led to pretty much me being where I am today. And I noticed a pattern of kind of unique reproductive health outcomes happening in all of the women in my family. And that got me interested because I was just wondering, why is that the case? Why is almost every woman in my family have this very unique story? But then what does that mean for me? And I just wanted to learn more. And since I was a little kid, I knew I wanted to use science to help people. So once I got to Texas A&M for my undergrad, I started looking more into reproductive health, just trying to figure out, where do I come into play? What is my role to play? How do I best use my privileges and power to help my community. And I realized after joining our student reproductive justice organization, that's where I was meant to be. I was meant to be in the field of public health, use health and science and education to make sure that young people especially feel empowered, just because when I was a young person, we knew what was going on with our peers. We would advocate for solutions, but then you'd have adults just not really take us seriously, and I hated it. And I was resolved that when I was the adult, I would never, ever treat young people that way. So that has kind of been another motivating factor, and that's led me to come to Yale to pursue my Master of Public Health. I want to pursue a PhD after I graduate with my MPH, and my whole goal is to focus on sexual and reproductive health of young people and making sure that they know they have the power to not only have control, but to advocate and to make sure that their community is just uplifted in the end. So I think that kind of summarizes my whole journey to where I am now.
Wonderful. Thank you for sharing that. I do want to ask, as a Texan, did that have any impact as well on your journey?
Sorry, did you say Texas?
As a Texan, growing up in Texas, I know that I started my reproductive health advocacy journey being angry at the time Governor Kasich in Ohio, where I'm from. So I wonder if growing up in Texas too had an impact on that.
Definitely. I think the first time I kind of understood reproductive health as a very conscious person was, I think it was 2013 when we had State Senator Wendy Davis do the filibuster in the Texas legislature, trying to just prevent, I believe, an anti-abortion law. And I think that's the first time the word abortion made any sense to me. And since then, I've kind of been keeping my eye. And once I got to undergrad, that's when I realized kind of what a disadvantage, unfortunately, being in Texas had with my whole healthcare, not just with repro. And I was trying to find ways to advocate, trying to find ways to fight that. And I will be probably talking about this later on in our chat, but that's when I started my distribution service, giving out reproductive healthcare products to people. And that's when I just realized that it's so fascinating how where a person is born can determine so much of their health outcomes and their life outcomes. So definitely being born and raised in Texas has impacted a lot of my experiences and me deciding what I wanted to do as a career and just live my life in general.
Absolutely. And especially now with the post-jobs world that we live in, the disparity of where people are geographically is that much more vast. So really glad to be having this conversation with you. And that what you just spoke about leads perfectly into my next question, which is, you talked about you help to give out and manage reproductive health kit services to students. Can you tell us about what that experience was like and what kind of responses you were receiving from students?
Definitely. So my reproductive justice student group back at A&M, they were already giving out Plan B, emergency contraception, condoms, and pregnancy tests for free to students at our student center. And then came the COVID pandemic, and they decided that, okay, we need something more systemized, just a better way that we can still be serving the student community, but not also putting people at risk of catching COVID. So that's when I joined the organization, and we just kind of systemized it even more just to make sure that when people would request what they needed, we could get it to them in a pretty quick and efficient manner. So we had emergency contraception, we had internal and external condoms, pregnancy tests, lube, dental dams, pads, and tampons. So we would just kind of tell folks, you can build your own kits. This is what we have. Choose what you need. And then I'd be the one coordinating when to give it to them. So during the COVID pandemic, so like 2020 to 2021, it was a contactless delivery. So we just go probably to their apartment or something, leave the bag there and leave. But then 21, once Texas and A&M started opening things up again, we were back on campus. I would go and coordinate times and locations where I would be on campus, and I would physically hand the bags to folks just to make sure that people got the products they requested and there wasn't any chance that they don't get it. And yeah, I mean, the reception was very overwhelming. I mean, I had students come and tell me, you don't know how much this is saving my life, or without you, I would be in such a terrible position. And that just reaffirmed, because I'd also just transferred into the public health major, and I was learning about community care and needs assessments and all these very public health academic stuff. But then to see this direct action validating the need to be centered on the community, but also making sure that right now people are being helped, it just validated that the work we were doing was right. And that's how we were able to get connected to Jane's Reprocess, which is an abortion fund in Texas, gave these little kits out to the community members as well. And then I took all the experience with me to Yale, have been doing similar distribution services here, and that's what led me to advocate for the vending machine and to be able to provide vending machines with products like emergency contraception. And now I'm working at the Connecticut legislature to make sure that now that we have the regulation that you can sell over-the-counter medication through a vending machine, how do we make sure this is sustainable and that campuses are looking out for their young people and actually enacting these things, which I'm super excited. We are pushing a bill this session, and fingers crossed for good news. But it has been, I mean, just the validation and all the support from the people we've been serving has definitely helped, I think, see this wave across the country of young people supporting each other and handing out these products, because we've got to look out for each other. If we don't, who will?
Yeah, I'm hearing very much from you and Kelly, you know, a real need to lean in and help your community. And this is why grassroots organizing is so important. So my last question for you at the moment is, what advice do you have for folks who want to become involved in sharing accurate, fact-based sex ed in their communities, or even handing out emergency contraception in their communities?
Yeah, so I think for sex ed, I think trying to learn as much as you can that is medically accurate, culturally sensitive, and just appropriate. I think that is a very needed. I think you can't really or educate others if you're not able to educate yourself. So taking that time, reading up, and not just reading like medical information, but also looking at people's experiences, listening to people's stories. I think that is also something helpful, which leads into my next advice, is that I think it's better when you just ask the question, hey, this is what I have, what do you need from me? Letting people take that control and ask for what they need, and then whatever resource, whatever education you can help provide. I think that's the best way to ensure that what we're doing is community centric. It is focused on the people, and also we're just respecting each other. We're loving each other. It's just this very mutual relationship. And then when it comes to distribution services, I do think that whatever way you're able to directly help your community, whether it is through passing out emergency contraception, whether it's knowing how to perform a self-managed abortion, whether it's knowing, okay, these are different resources you can access, just knowing things and being willing to help people. I think that's the most important thing, because we're seeing with different laws at the federal, and then depending what state you live in, there's just all this negative news and negative energy and just these bad things happening. So I do think that if we are able to kind of look inwards to our community and help each other, and then take these lessons and then come out and then help the larger community, I think that is something that is going to be so valuable in these next couple of years during this administration.
That is very true. Thank you so much, Nimisha, for sharing that with us, and for taking the time to speak. I can't wait to speak to you more during our Q&A session. So thank you so much. And I will pass it over to my co-host to introduce our next panelist.
Hi, thank you, Jessica. I have Alyssa Wagner with me on the phone, and Alyssa Wagner is And Alyssa Wagner is the medical director at Hey Jane. She is a board certified women's health nurse and practitioner specializing in reproductive and sexual health care. Prior to her role as head of medical at Hey Jane, Alyssa served as the lead clinician and director of nursing at the Cuyahoga County Board of Health and as a clinician at the Northeast Ohio Women's Center, an independent abortion clinic in Cleveland. Alyssa completed her bachelor's degree from the University of California, Davis, her master's degree from Case Western Reserve University, and her doctoral degree at the University of Michigan, and served on the faculty of Case Western Reserve University. She's passionate about increasing access to patient-centered healthcare. And I have Alyssa with me right now. Thank you for speaking with us, Alyssa.
Yeah, thanks for having me.
So the first question we have for you is, what drove you to specialize in reproductive and sexual health care?
Yeah, definitely. Well, so I have always really valued meeting patients where they are. And I think that reproductive health care is one of the best places to do that. It's where you really get to talk to a patient about what's best for them right now. And I've always been really drawn to kind of that level of shared decision making and, body autonomy in general. So yeah, I've been over 15 years of working in abortion services. It has just always been a really good place for me. I enjoy my patients. I enjoy the relief that they get. I enjoy combating the stigma that they have unfortunately been heavily exposed to. And yeah, that's kind of how I got into it.
Awesome. I can't imagine all of the changes that you've weathered working in this space for 15 years. And to that end, I was kind of wondering if you could talk about what kind of common misconceptions that you deal with at your job around emergency birth control and medication abortion.
Oh yeah, definitely. And like it was already brought up, this has been a narrative that has been pushed by the anti-choice movement, but people are very frequently misunderstanding the difference. I've had patients who were in line behind patients buying Plan B and say, I could never have an abortion. And, whoa, they're not the same thing. So there's a lot of misinformation, a lot of myths. A lot of patients and non-patients think that they are the same, but they are in fact different. Yeah. I can also go into the differences. I don't know if that's going to be a separate question.
No, you can totally go into the differences.
Yeah, sounds good. So I think that some of the misinformation does come from the fact that some of these drugs are a little bit related, like maybe cousins of sorts, in the way that they work. So progesterone is a hormone in the body, and this hormone is super important for pregnancy. It's super important for the menstrual cycle. It's super important for ovulation. And the way that these medications work is they kind of block that hormone. Now, at different stages in your menstrual cycle, that would do different things. The dose that we give of this medication for Plan B, or Ella, which is a prescription Plan B, slightly different medication, that those won't stop a pregnancy if you've already ovulated. The way that they work is by delaying ovulation until sperm is not really an issue anymore. So sperm can live for about 5 days, which I know gives a lot of folks the ick, but it is important to know. And so these medications will delay ovulation until sperm isn't available to fertilize an egg. Now, a lot of patients will be like, I don't understand. I took Plan B. How did I get pregnant? Well, if you've already ovulated, these medications can't prevent ovulation. Now, the medication in a medication abortion, which is called mifepristone, along with misoprostol, works differently. Mifepristone actually stops a pregnancy from growing when it's inside the uterus. And then misoprostol, which is the second step of a medication abortion, helps empty your uterus. So as you can see, even though the medications work on progesterone, so they're a little bit related, they're very different.
Thank you so much for explaining the difference and leading into your medical expertise and explaining it way better than we could. Could you also go into how Hey Jane can help support those who are looking for reproductive care?
Yes, yes. Okay, so I always say the best time to get emergency contraception is before you need it. I like to say take the emergency out of emergency contraception. This is something that anybody who can get pregnant or knows someone who get pregnant should keep in their bathroom cabinet, you know, like Tylenol, like ibuprofen. This should just be in your arsenal of care for people. So it is, I think, really important, if not now, you know, forever, to have emergency contraception available on hand before you need it, especially because we know that the sooner you take it, the better it works, because you want to take it before you ovulate, and you could ovulate. Additionally, there are resources to get medication abortion similarly, to have it available. Through Hey Jane right now, we treat people who are pregnant, so who need a medication abortion. But getting involved with different abortion networks, abortion funds, is a great place to get involved in some of this work for reproductive health. We also have what's called the Unwhisper Network, which is kind of our advocacy network for people who are interested in, you know, getting more resources on educating their communities and their friends.
Awesome. And I know that outside of emergency contraception and medication abortion, Hey Jane also offers other reproductive and sexual well-being services. Could you also talk a little bit more about those?
Yeah, definitely. So we also offer birth control, which is, you know, obviously a great option for people who are not wanting to be pregnant. We do infection care, so UTI, bacterial vaginosis, yeast infections. We can do herpes treatments. Basically, we are like a reproductive healthcare home that is all virtual. We're contracted with insurance. We also are accepting of cash pay patients. So really, anybody can see us for, you know, any of these reproductive health needs, kind of on their own terms. The way you can access care with us is with video visits, or you can chat with us, and that seems to work really, really well for our patients of all types. So our abortion patients, emergency contraception patients. This model of care is one that our patients really enjoy, and that we know works really well to get them the care that they need and deserve.
That's awesome. I love that you guys are able to provide all of these services in one place. And I want to thank you again for answering our questions. We'll be going more into questions during the Q&A portion. But for now, I'm going to pass it back to Jessica.
Thanks.
Thank you so much, Jasmine and Alyssa. So here are some additional resources from the organizations representing our panel today. And then Reproaction has a emergency contraception versus medication abortion video as well. And then there's some databases for you on birth control pharmacies. And you can plug into Reproaction campaigns at reproaction.org, and then on social media at Reproaction. And save a date for our next webinar. That will be Monday, March 24th at 2 p.m. We will be talking about the criminalization of pregnancy outcomes. All right, and we are into the Q&A section. So if you have questions, please enter them. But first, I will ask a question. I would like each panelist to answer this if they can. And that is there anything regarding sexual and reproductive health care that continues to surprise you despite your experiences? And that could be working, you know, with patients, people's questions and answers, or just generally working in the field. Is there anything that continues to surprise you? Kelly, would you mind going first?
Sure. No. I would say one thing that surprises me, continues to surprise me in a good way, because there's a lot of things that surprise me in a bad way, but I want to be supportive and excited about just the energy of youth and the energy of community organizers. A lot of the work that we do is really standing behind and supporting folks in communities and on campuses who are taking care of each other, like Nimisha talked about. And I just am so thrilled about the level of energy and commitment and care that people bring to to this work, whether it's, direct peer-to-peer distribution like Nimisha was talking about. A whole other area of work that we didn't get to talk about too much was advocating for vending machines on college campuses. Nimisha has been instrumental in helping to make that happen in Connecticut. So I just am excited about the energy, the good stuff that's happening, and it kind of keeps me going in the midst of all of the bad.
I love that. Always lovely to have good things that continue to surprise you throughout this work. Nimisha, did you have anything that surprises you about this work or continues to, I don't know, shock you? Oh, sorry, I had muted you. You're unmuted.
There we go. Perfect. I think something that surprised me, again, like Kelly said, in a good way, I'm just kind of encouraged by how much is still left to support and advocate for. I think it's actually a good thing. Like, yeah, there's bad stuff happening. It's unfortunate, but the fact that I think we're able to keep on fighting, that we keep seeing new people show up, and these new people, they're bringing in new ideas, they're bringing in new things for us to think and talk about. It surprises me every day that there's never a typical day, and I personally love that. I think for a lot of folks that can do like the 9-to-5 desk job, that's amazing. I wish that could be me, but I love the new surprise and the new kind of things that are thrown my way. So I think it's just so fun that there's never I would say, standard day, and every day is something new, which, yeah, I love that.
Awesome. Thank you. Okay, can I have Jasmine, can you unmute yourself so Alyssa can answer?
Yes, absolutely. Alyssa, you're on.
Sounds good. So I would say definitely echoing what everybody else has said about the nice surprises of, people showing up saying that this type of care is important. I would say that one thing that continues to surprise me, and it's hard to surprise me at this stage of the game, is probably the number of patients who, when accessing this care, feel so isolated. I feel like I, shout every day to everyone that will listen that, this is normal, this is very common. And that everyone is accessing this type of care. So don't feel alone, and don't feel stigmatized, even though I know that there's a lot of people doing a lot of work to try and make you feel bad about it. Emergency contraception, birth control, abortion care, these are all very common, and more people than you would know are accessing it.
Wonderful, thank you. And stay on the line, Alyssa, because the next question is directed to you. Can you clarify a point that you made earlier? If you are ovulating and you have unprotected sex, all EC won't work, or you need a different type?
That's a really good question. So if you have already ovulated, so if the egg has already been released, then EC won't work. There are some studies looking at IUDs and whether or not they could prevent a pregnancy if you've already ovulated. Could it inhibit the sperm and the egg attaching? That being said, the oral types like Plan B or Ella, those, if you've already ovulated, will not work.
Got it. Thank you. And another question for you, Alyssa. Sorry, I'll get around to the other ones. This is a specific question. So I had heard previously that you could go to a provider and preemptively get a prescription for emergency contraception to then hold it on hand, and it would be a lot less expensive than getting it like the $60 over-the-counter Plan B. Is that something that's true, or does it vary state by state now?
Oh, that is something that is true, and I really wish more people knew about it. So insurance is required to cover birth control, and emergency contraception falls under that. It doesn't mean that your plan will cover Ella. it might only cover Plan B. But if you can get a prescription to have on hand for emergency contraception and use your insurance, then there's a really good chance that some form of emergency contraception will be free for you. Without a prescription, you can't get Ella. You would only be able to get Plan B. And while the prices for that can be good, it can be out of reach for a lot of folks. So yeah, if you have insurance, use it. Get a prescription for Ella or Plan B or both to see which one, your plan will cover. And then you'll save some money, hopefully, by using your insurance at the pharmacy to pick it up. That's a great question.
Great, thank you. I want to direct this next question to Kelly. Are there other questions that folks should be asking their healthcare providers when discussing emergency contraception or medication abortion? I believe you had mentioned that there are still like some providers out there who are giving wrong information about that. So are there any questions that people can walk into their doctor's office ahead of time with?
Yeah, I mean, I love what Alyssa said about advanced provision of EC, and really, there's some evidence that Plan B may not work for folks who weigh more than 165 pounds. The research is not very good, to be honest, and so we don't like to lean on that too much. But what we do lean on is that Ella is a more effective product for anybody, regardless of weight. It works better than Plan B because it works closer to the time of ovulation. I have a beautiful little slide presentation about how these things work in lots and lots of detail. But we recommend that everybody have Ella on hand before you need it. And so one of the challenges with getting Ella is that it's often not available for same-day pickup in pharmacies. So there have been several different studies, including from our group, that have found that only about 10% of pharmacies keep Ella in stock ready to dispense that day. And of course, EC is really time sensitive. So even though the label may say you can take it up to 3 days from unprotected sex or 5 days, the reality is that because it works by preventing or delaying ovulation, you need to take it right away unless you are certain that you know when ovulation is happening, which, let's be honest, not many of us know that. So, I think I would go to a healthcare provider if you're someone who's at risk of pregnancy and say, look, I'd like to have a prescription for Ella. And you can also ask your doctor to call the pharmacy near you and form a connection and create a relationship and say, look, pharmacy, if you agree to stock Ella, I will refer all my patients to you. Because the reason that the pharmacies don't stock Ella mostly is not because they're against it. It's mostly because they don't get a lot of prescriptions for it. And then the product expires on the shelf. So I would say, doctors and all healthcare providers have a really important role to play in this negative feedback loop and breaking this cycle of lack of availability. I also think it's a really good idea to talk to your healthcare provider about abortion. And, maybe you don't need an abortion now, or maybe your partner doesn't need an abortion, but are they someone that you could go to if you needed help? Whether you're in a state where abortion care is legal or you're in a place where abortion care isn't, what would they do to help you? What kind of guidance would they offer? I think this is a time that's really important to understand the values of the people around us. And, your doctor works for you. So if you don't like what they have to say about access to reproductive health care, you could find somebody else.
Absolutely. That is a lesson I wish I knew when I was much younger. I had a gynecologist who wouldn't give me the birth control option that I preferred. And so and then I told friends and they were like, get a new doctor. And I was like, oh my gosh, you can do that. So that's what I did. So yes, absolutely. Thank you for that answer. The next question from our attendees, I'm going to direct towards Nimisha, and that is, Where can I learn more about vending machines so that I can talk to my representative about that option? And then also, did you experience any issues with anti-abortion folks trying to buy out the Plan B vending machines, or attempting to sabotage the work focused on that?
Yeah, so I would, for the information about vending machines, I would look at ec4ec.org. We have an entire tab dedicated to what the idea of the vending machines are, how you can implement it, how you can talk to people about it. So that's the resource I would go to for vending machines. And then talking about anti-abortion folks, what we did with our services is we make sure that people can only request a kit once a month, just so that, and I mean, it is to make sure that we have enough product for everybody who requests to get it, but it also does help make sure that there aren't, like you said, and any anti-abortion folks trying to request a whole bunch so they can go destroy it. I haven't seen that directly in the work that I do, but I have definitely heard about that at other campuses, and that's why a lot of student activists, when we heard about that, we started putting a little bit of a restriction on how often someone can request. And then also at Texas A&M, there was a very strong anti-abortion student activism presence. So another thing we did for our safety and to make sure we had enough product for people that needed it is we did ask for the phone number, so we could actually, I mean, we use it to coordinate with the requester, but also it is unlikely that someone's going to make multiple phone numbers to kind of get these. And then also, if I'm meeting them face to face, I'm going to recognize. So there's different ways we have tried to make sure that doesn't happen. Could it still happen? Of course, but I haven't seen it in my work. And we use these different tactics to make sure that we are doing the best we can to make sure that we still have emergency contraception, pregnancy tests, condoms for people. But yeah, that is what we have done.
Got it. Thank you for sharing that. And this goes back to something that was said earlier in the panel, which is, the use of medication, abortion, and emergency contraception is so widespread that, even if antis are signing up for it, people who are anti-abortion still take these medications. And they will use them. So thank you for sharing your experience on that. And resources that are discussed today will be sent out in the follow-up email, and will also be on our resource link along with this recording of the webinar. Wonderful. So I want to ask Kelly and Alyssa, whoever wants to go first, is there anything else about the difference between emergency contraception and medication abortion that we haven't touched on, or that you want to delve more deeply into?
Yeah, I would say one thing that folks may start hearing about is
one thing that I just also like to warn people about is that, some insurance companies will require that you get a prior authorization for some of these services. And so I think doubling down on, what was brought up earlier about having a provider who is in your corner is really important, because, prior authorizations take 5 days at a minimum. And so having that requirement does put emergency contraception and sometimes abortion out of reach for folks. So I think just doubling down on having a provider who is, aligned with what you want and what you need, and is able to work on that with you to make sure you get the care you need.
Great. Thank you, Alyssa. Kelly, go ahead.
I think one thing that folks may hear a little bit more and more about is a new study came out last month that looked at the active ingredient in Ella, the prescription-only emergency contraceptive pill, in combination with misoprostol for medication abortion. I think this, it's a very small study. It's too small to really change clinical practice, doesn't have any control groups. Hit me up if you want to hear a full description of the challenges that I see with this study. But I think, one very predictable consequence is further confusion about the difference between EC and medication abortion. It's unlikely that using ulipristal acetate for abortion is going to improve abortion access in the United States, but it could lead to some more restrictions on EC. So if you start to sort of hear more rhetoric about Ella being the abortion pill and being the same as abortion, and now we know the liberals have been lying to us all along, that's why you're hearing it. And again, just get out there and be super clear, that you support access to EC and abortion and every method that folks need to decide when and if and whether they become a parent, but also that these things are different. And, ulipristal acetate would not work for abortion without misoprostol. Because misoprostol alone is really effective for abortion. So just be really loud and proud about your values and make sure you're well informed. And, when you're not sure what's going on, look for some resources. And we've got a resource about this study. And I'd be, we can send it out after the call to make sure that folks have a good resource for background on this.
Great. Thank you so much, Kelly. This has been a really informative webinar for myself, so I hope our attendees and folks listening to this recording after the fact also feel that way, walking away from it. I thank you so much to our panelists, Alyssa, Kelly, and Namisha, for your time and expertise. Like I said, we will share the resources that have been spoken about after the fact in a follow-up email. Thank you so much to my co-host Jasmine for helping putting this together for this timely discussion. And yes, thank you for everybody for attending. And I hope you all have a great rest of your day and take care, everybody. Bye.